Dr. Chikwe, this is Chris. Do you hearing us okay?
Yeah, hi Chris, loud and clear.
Excellent. That looks like a good connection to you. Thank you for joining, sir.
Thanks.
RD, are you hearing us okay? This is Geneva calling Professor Janabi. Do you hear us okay?
I can hear you very clear.
Thank you, sir. Thank you for joining us today. If you could turn your camera on as well, as soon as you can, and then please leave the cameras on. That helps us map the cameras into our system. That would be fantastic. Thank you, sir.
Can you see me clearly?
I can see you. Thank you so much.
Yeah, we were just adjusting something here. Thank you.
Okay. Thank you for joining, sir. You can mute your audio. Just leave the camera on. Thank you. Bonjour, bonjour. Regarde, on a changé pour vous. Janet Diaz, welcome. If you could please turn on your camera and let us know if you can hear us okay. Thank you so much. You're hearing okay?
Hi, can you hear me?
I hear you.
Yeah, I hear you.
Perfectly well. If you could please leave on your camera
right.
at this point as well, that would be very helpful to us.
Thanks.
Welcome, Dr. Abdi. If you're hearing us okay, could you please do a quick audio check? I see you well.
Hi, Chris. Can you hear me?
I hear you well. Thank you, sir. Welcome. And if you could leave your camera on, please, from this point on, that would be great. Okay, to those on the Zoom, I'll probably open up very shortly to journalists. So after about 2 minutes, you'll see journalists starting to arrive into the room. And here in Geneva, we already have some media colleagues joining us. So we will take it from there. Paul, any news on the start time? We don't know. Paul, as Paul says, we're scheduled for 3 p.m. as far as we know. That's roughly holding, so please stand by. Okay, it's 3 o'clock, so I am opening up the Zoom to journalists. Dr. Abdi, please, if you could leave your camera on, that would be really helpful to us. Thank you so much.
Recording in progress.
Greetings from the WHO headquarters in Geneva. My name is Amna and I welcome you to our press conference on Ebola disease caused by Bundibugyo virus. To update you on the situation and to answer your questions, we have the experts here in the room, and a number of speakers are joining us online from Bunia in the DRC. In the room today, we also have the UN Geneva accredited journalists, in addition to the reporters who have joined us online. Warm welcome to you all. After I introduce the speakers, I'm going to go to the Director General for his opening remarks, and I will then open the floor to your questions. We will start with the journalists in the room, and we'll move on then to the reporters online. As always, Dr. Tedros, WHO Director General, is with us today, and we also have online Dr. Mohamed Yaqub Janabi, Regional Director for WHO Afro. Welcome to you both. Joining us from Bunia in the DRC, speakers online, we have a group of experts, starting with Dr. Chikwe Ihekweazu, who is the Executive Director of the WHO Health Emergencies Program. We have Dr. Marie-Roseline Belizer, who is the WHO Afro Regional Emergency Director, AI and Incident Manager. We also have Dr. Abdirahman Mahmoud, the Director of Health. Dr. Janet Diaz, the Unit Head for Safe and Scalable Care, is also with us, as is Dr. Vazi Morthy, who is the Lead ad interim for the R&D Blueprint in the Office of the WHO Chief Scientist. With this, I'm going to hand over to Dr. Tedros for his introductory remarks.
Thank you, Amna. Good afternoon to everyone in the room, and good morning, good afternoon, and good evening to those joining us online. Yesterday, I returned from a visit to the Democratic Republic of the Congo, including to the epicenter of the Ebola outbreak in the province of Ituri. I met with political leaders, senior health officials, ambassadors, partners, WHO colleagues, frontline responders, community and faith leaders, women's groups, business leaders, traditional healers, and more. Of course, meetings also with our partners. I'm very encouraged by the level of commitment I saw everywhere I went. What I saw gave me hope, although challenges remain. In DRC, 344 cases have been confirmed, including 60 deaths in 24 health zones across 3 different provinces: Ituri, North Kivu, and South Kivu. The number of suspected cases has now been reduced to 116 from over 1,000 last week, as we work through the backlog, either confirming them or ruling them out. In Uganda, there is 1 confirmed death and 15 confirmed cases, including a Congolese resident who traveled to the United Arab Emirates and then to Uganda. WHO is working with public health authorities in Uganda and the UAE to gather additional information, assess the risk of exposure during travel, and to facilitate contact tracing. We thank both the UAE and Uganda for their collaboration to mitigate the risks related to this case. In addition, a US citizen who was infected in DRC is still receiving care in Germany. WHO's risk assessment remains unchanged, very high at the national level, high at the regional level, and low at the global level. The outbreak had a big head start, and we're still behind, but under the leadership of the government of DRC, we're catching up. In Bunia, there are now 3 treatment centers with a capacity of 80 beds, and there are also treatment units in Mangwalu, Raumpara, Beni, Goma, and Bukavu, and more are on the way. So far, 6 people have recovered in DRC and 2 in Uganda, showing that people can survive Ebola if they have access to care and go to health facilities as soon as they show symptoms. But we still face several challenges. First, testing. One of our key priorities is to scale up laboratory and diagnostic capacity to reduce delays in case confirmation and support faster response decisions. Accordingly, we're working to decentralize laboratory and diagnostic capacity in priority locations, including Mangwalu, Beni, Aru, Yaoundé, and Chomia. We also need to scale up readiness, including surveillance, laboratory diagnostics, and access to health services in neighboring provinces and countries. Second, contact tracing in the DRC is not yet where it needs to be. Only about 45% of contacts have been followed up, and to get ahead of the outbreak, we need to get that number up to above 90%. Insecurity, displacement, and mobile populations make contact tracing especially difficult. Third, blanket travel restrictions imposed by some countries are disrupting supply chains and hindering the response. WHO recommends exit screening at airports, ports, and border crossings to prevent the exportation of cases and contacts. We ask countries that have imposed blanket travel restrictions to lift them. Fourth, community mistrust is a serious barrier. Some community leaders told me that they believe Ebola is not real. Building trust with the communities is therefore critical to bringing the outbreak under control. And fifth, as you know, we're fighting this outbreak without vaccines or therapeutics. WHO and partners are working on advancing clinical trials as quickly as possible. Today, I convene for the second time the principals of the Interim Medical Countermeasures Network to align on 3 priorities. First, increasing support for decentralized diagnostics. Second, mobilizing immediate support for the affected countries to lead clinical trials in cooperation with communities. And third, accelerating the investment to support all pillars of the response. Although vaccines and therapeutics would be a big help, the key to ending this outbreak is not biomedical. It's leadership, ownership, partnership, and trust. Government leadership, community ownership, a strong partnership between the many actors involved, working with one budget, one plan, and one report, and building trust in the affected communities. We also need to remember that Ebola is only one health threat among many that these communities face. One of the things I heard from the community leaders is that they worry that the response to Ebola may take resources away from the health and humanitarian services they rely on for their many other needs. Our ultimate measure of success is not whether we stop this outbreak. We will. The government of DRC has extensive experience with Ebola and has stopped 16 previous outbreaks. It's just a matter of how quickly we can do it. The real measure of success is what we do to prevent the 18th outbreak and the 19th. If the people of Ituri survive Ebola only to die from malaria, malnutrition, or pneumonia, or diarrheal disease, or HIV, or diabetes, we have not really helped them. For now, WHO and our partners are committed to ending this outbreak under the leadership of the government. And when it does end, we will remain equally committed to supporting the government and the local communities to build the health and humanitarian services they need and deserve. Amna, back to you.
Thank you very much, DG. Before we open the floor for questions, I want to introduce our experts at the podium. We have got to the right of Dr. Tedros, we have Anais Legand, who is the Technical Officer for High Threat Pathogens at the WHO Health Emergencies Program, and Dr. Teresa Zakaria, who is the Unit Head for Risk Reduction and Humanitarian Operations at the WHO Health Emergencies Program. We are ready to take your questions. Agnes Pedrero, IFP, over to you, please.
Yes, hi, thank you. A question to who can answer that question. I was wondering if you could tell us how much access do you have on the tests that actually can detect the strain, this particular strain, and if there is any test shortages, and in general, what are the most crucial need that you have on the material, on the personnel? Is there any shortages in general? And if you could also say what is the number of suspected Ebola deaths that have been found so far? Thank you.
Thank you, Agnes. For the first part of your questions, let us go to Dr. Marie-Roseline Belizer, WHO Afro-Regional Emergency Director ad interim and Incident Manager. Marie-Roseline?
Thank you for giving me the floor. Can you see me?
Yes, we can hear you. Go ahead.
Thank you
please.
for giving Okay, thank you. Can you repeat the question, please?
Agnes, go ahead, please.
So I repeat the question.
The first part, yes, about the diagnostics.
Okay. So my question was about in general, about the material, the personnel, if you see any shortages on the ground, on what on the most critical needs, and in particular on the tests that can detect this particular strain, the Bundibugyo. What can you tell us about that? Thank you.
Okay, thank you so much for the question. So far, WHO, we have deployed 106 staff in the field, and that are distributed in 3 provinces. But at national level, we have a lot of infrastructure that has been infected, and we are putting those personnel in quarantines. That means there will be a shortage of national personnel in those places. And we support the Ministry of Health in order to take other healthcare workers in other provinces in order to replace those personnel in the province. Yesterday, we have 30 healthcare professionals arriving from Kinshasa in order to support clinical care here. And regarding on the test, WHO supported the Ministry of Health to have 2,000 tests that has been deployed already in Bunia. And today, a mobile laboratory has been deployed in Mongwalu, which is the second hotspot of this outbreak. And we still have a shortage of staff. For example, in WHO, we prevent, with the scale up that we are doing, we are planning to deploy 278 staff. So far we are at 38% of what we have a plan. And at local level, as I say, we also have other institutions who have also staff. For example, MSF is running a clinical treatment center. We have also Alima, who has a staff. We have a Samaritan Purse, who have also staff, and all of them are coming on to support the government. But for the national one, as I mentioned, we are supporting the government in order to protect those healthcare personnel. As you know, we have a high number of them that has been infected, and we are really putting in place that biosecurity system in order for those staff to be in a safe place. In the meantime, the service continue to run with our staff coming from other provinces, as I mentioned. Over.
Thank you, Dr. Belizer. And on AFP's second question, which is related to suspected deaths and the numbers, we will go to Dr. Abdirahman Mahamoud, the Director of Health Emergency Alert and Response Operations. Dr. Mahamoud.
Thank you so much. DG has already alluded and explained the current situation. What the field team is doing, looking, clearing the backlog. So the lab so far has done 1,445 tests that cleared almost all the backlog we had. And every day, as the surveillance improves, there are new suspect cases. So today we have 116. The historical 223 deaths, there's a dedicated team going through that case by case, whether it's a probable, whether it's a discarded, or unknown. So that work is going out on the field. So the numbers are there and they have not missing from the overall. It's just the work required. At the start of the outbreak, every death was included. And now that we have the surge, as Dr. Mary Rosalind said, we will be going through that and classifying. They're already dead, so we will not be able to collect samples, but we have enough clinical information from the medical record and the epidemiological investigation going on that. So the lab has improved, and I think with the decentralization, they will be able to do 1,000 tests a day from the small number. With the 5 labs that will be established by early next week, we're in a good shape under the government, and I'd like to recognize the INRP team, Professor Muyembe and Professor Palisid, who's leading here from the front. So at this stage, WHO, with the support of Africa CDC, the scale-up is on track.
Thank you, Dr. Mahamoud. The next question goes to Catherine Fianco, France 24. Catherine.
Thank you, Anna, and thank you to the DG and his team for briefing on Ebola. I have 2 questions. My first is regarding the financial need, the finances needed to increase the testing and care capacity. As you mentioned that it's needed, DG, and also regarding vaccines, how is the research going on? Where is it going on? I read some articles talking about some possibilities to work with Moderna. Could you give us some details about that? Or other companies are investing also in the research on vaccine, and how long it is going to take, as far as you know? And my last question is regarding North Kivu, Goma. Do you have access to Goma, and how do you deal with the region? Thank you.
Thank you, Catherine. Let us start with Dr. Vasi Morthy from the R&D Blueprint to answer your questions on the vaccine research and development, and then we will move on to your other questions. Dr. Morthy?
Thank you. Can you hear me okay?
Yes, we can. Please go ahead.
Yes. Yes, thank you for the question. So there are three that are now under development specifically for Bundibugyo. So this is positive. There is the Oxford vaccine in cooperation with the Serum Institute of India. There is Moderna, as you mentioned. So Moderna have announced since the last press conference that they are now actively accelerating development of a Bundibugyo specific vaccine. And in addition to that, IRV is working on a vaccine. The first two, in terms of timelines, are Moderna and Oxford with Serum Institute of India. We're looking at 2 to 3 months before the vaccine doses could be available for clinical trial. The IRV one will take longer, potentially 7 to 9 months, they have said. Thank you.
Thank you, Dr. Morthy. For the questions related to access and response in North Kivu and in Goma, let me check if RD Afro can start us off. Dr. Janabi?
Yeah, thank you. Can you hear me clearly?
Yes, we can. Please go ahead.
Yeah, thank you. Let me just allow me to start by strongly reinforcing the DG's message about the importance of leadership presence on the ground, of course, led by the government of DRC and working with all other agencies, including CDC. And really, I have to mention MONUSCO here, who really help us on the transportations in the initial stage, and many others who work with us. Our visit with DG to Ituri was a clear demonstration of the WHO solidarity with affected communities, national authorities, and our frontline responders. It reassured our teams and partners that this response is being led by urgency and visibility and commitment at the highest level. As all of us, we were there. The DG was there, Chikwe was there, and our RED was there. So the visit also delivered very concrete operational gains. DG engaged directly, as he said, with community leaders, youth, traditional leaders, and local influencers, reinforcing that community trust is central in controlling this Ebola. We opened, as DG said, a 60-bed treatment center, which will have also a pediatric wing, specific for pediatric wings. DG, with all the team, continue to address the misinformation with very clear facts, including clarifying the timing of WHO outbreak notification, the reopening of commercial flights between Kinshasa and Bunia, which he really requested the government there, is another very important outcome, already improving access, logistic, and continuity of the response. As DG has stated, this outbreak is serious, but is controllable. Transmission is still ongoing, and contact tracing coverage, as he put it, currently around 45. Our target is to reach 95, and we're going to do it in phase. We started at 20, so now we're at 45. So really, there's a light end of the tunnel. Insecurity and localized conflicts continue to affect this coverage, and border disruption impacts supply chains. So these challenges are real, but they are known and being actively addressed. Our priorities to finish are therefore very clear and fully aligned: sustain community engagement, protection, support for frontline health workers, and rapid identification of the cases. Specifically about Kivu, we have never left Kivu as WHO. That's why we even give you the numbers. We have always been there. We are just now drawing attention to the current Ebola, but we are not only looking to Ebola. I have to remind everyone, 12% of the malaria cases are in the Democratic Republic of. So all our surveillance points, our treatment centers, when we are going to involve diagnosis of malaria and treatment of malaria. So let me finish with consistency, implementation of these measures, close collaboration with the national authorities, and trust of the communities. We are confident But the other thing, DG touched it, but let me emphasize. Now we are looking on the longer term in order maybe to reduce the chances of getting the 18th and 19th and 20th. We have to go down. Where does Ebola coming from? It comes from the animal. It's a zoonotic disease. So we have to start to think about talking with the indigenous people. One of the delicacies is the wild animals, the fruit beds. So how can we start the process of discussing with them how to handle these things, how to handle the animals and the beds and everything is very crucial. Back to you, Amna.
Thank you very much, RD. Catherine, could I please ask you to repeat your question on finances?
It was regarding finances. How much money is still needed to help fight this outbreak? Thank you.
Thank you. We will go to Dr. Chikwe to help us out. Please, Dr. Chikwe.
Thank you very much. Very important question. Firstly, just to say that at the start of the outbreak, we immediately, the Director General released $3.9 million from our contingency fund for emergencies. This is a very important fund that enables us to start any response. So that's what we've used to start the response to the outbreak. Currently, we estimate our costs, our needs for the initial 3 months of the outbreak to be $115 million. That will be part of a strategic preparedness and response plan that is being launched on Friday, done together with our partners in Africa CDC, the Democratic Republic of Congo and Uganda and all the other partners that are part of that response. So this is what WHO needs, but it's part of a much bigger requirement for the total response. Of what WHO needs, of that 115, we are only 35% funded at the moment for this initial period. And considering the scale of the outbreak, we estimate we will need a lot more for the duration of the response. However, we are doing the very best we can with what we have. We have mobilized fully to the field, supporting the government and working with many other partners. What we bring to the table is not necessarily primary financial. The money is important to enable the response, but there's a very strong response happening in the DRC, in Bunia, where I am at the moment. Partners are working ahead of the resources and really anticipating that, as usual, the world will come together, not as an act of charity, but as an act of solidarity to support the ongoing response in Bunia and the rest of the DRC. Back to you, Amna.
Thank you very much, Dr. Chikwe. We will turn now to the reporters online, and we have got a question from Nigeria Health Watch. Please unmute yourself, introduce yourself, and ask the question.
Thank you, Amma. Good morning, good day, everyone, wherever you are. My question, this is Emeka from Nigeria Health Watch. We would really like to know what WHO's advice is to countries within the region, especially as WHO has placed countries in high risk, and also what WHO is doing differently now to build trust in communities in DRC, given that this is not the first Ebola outbreak. Thank you.
Thank you very much. We will go to Dr. Abdi with this question. Dr. Abdi.
Thanks so much. Our regional office and the leadership of our regional director, Dr. Yakub, has been working with all the member states in the region. When we talk about the region high, maybe it's there in detail of this outbreak, we mean the neighboring countries, that's South Sudan and Uganda, and we have 10 other countries that needs to be ready. What we're doing right now is bringing the government leadership. Dr. Janabi had a meeting with all the head of state ministers in ensuring the risk. We are live in an interconnected continent. Together with the leadership of Africa CDC, we go with one plan in support of the member state. So I think what's really critically different in this response is starting with the community, because we know very well is the community ownership and the leadership, but going all the way to the head of state and the ministries of health. So it's one plan for Africa, led by the Africans, in solving the African problem, together with the global solidarity. So our recommendation for the other countries is to get ready. Ebola is not the only problem. In all these countries, viral hemorrhagic, where there's a Lassa fever in Nigeria, or the previous outbreak. So is the emergency preparedness and readiness as an element of the IHR amendment. So all the countries have to go through the IHR core capacity to be ready for this outbreak, but also for the subsequent outbreaks. So I just would like to give to Dr. Janabi if you would like to add additional points from Africa point of view.
Yeah, thank you very much, Abdi. You said it correctly. I've met all the ministers. I've spoken and met physically with the minister from DRC, and the Minister of Communication was always involved while I was in Ituri. I'm on the telephone with the Principal Secretary of Uganda. As you know, Uganda, the minister has not been sworn yet. I've been online with the Minister of Sudan, and tomorrow at 11 o'clock, we are having a joint meeting, which I'm going to chair it with all the four ministers, two from DRC, Dr. Diana Atwine from Uganda, and the minister from South Sudan, because the message is very clear to neighboring countries: must remain vigilant, strengthen the border health surveillance, share information very quickly, keep borders open for essential supplies, deploy our regional emergency teams, and engage communities and faith leaders to build the trust and secure humanitarian truces where necessary, where conflict exists. I believe I've always talked with them. Solidarity and cooperation is the backbone of this outbreak control. So we continue to engage with them in all means which we can. Thank you. Back to you, Amna.
Thank you, Dr. Janabi. Dr. Belizer, anything you wanted to add on this one?
Thank you so much. Maybe I can add that in the point of view of the countries that are at high risk, so we already take specific actions. One of them is the evaluation of all their capacity in order to respond or to detect to one case of hemorrhagic fever, namely Ebola. So we already have a dashboard of their capacity that we can share, that everyone will see which country has each capacity. So far, we already also deployed 3 staff in South Sudan that will be there to support their contingency plan. All the high-risk countries has already reviewed their contingency plan and budgeted that contingency plan. 3 staff have been deployed in South Sudan, and some of the countries has received a small funding in order to start with the simulation exercise and also to review their capacity for clinical care. Some countries have identified places where they will put patients if these become positive for Ebola. And each country also will receive 500 PPE that will be pre-positioned in all of those countries. So far, we have 10 high-risk countries, but however, how we are responding to a FIC, all the countries also are part of a preparedness plan in the Africa region. Over.
Thank you very much, Dr. Belizer. Dr. Zakaria, you had something?
Thank you. Perhaps just on the second question as well, on what is it that we are doing to make sure that we have the trust of people. I think it's very important here to fully recognize as well that there's a lot of suffering happening in the 3 provinces of DRC. There's also equally a lot of suffering in South Sudan, and Uganda hosts a lot of refugee populations as well. And so it is critical that health service provision is maintained, and that is an integral part of our strategic plan to comprehensively respond to the current Ebola outbreak. We have over 50 health cluster partners, mostly Congolese organizations, operating and delivering services in close to 500 health facilities across North Kivu, South Kivu, and Ituri. And it is critical that we provide all the means that they need to be protected, to continue service delivery, and also then to contribute to the response of the ongoing BVD outbreak. health has actually been instrumental in securing access to conflict-affected areas in North Kivu and South Kivu since last year. And so we want to also capitalize on that established relationship with health authorities in all locations to make sure that the BVD response can be as effective as possible, reach all the populations in need, while also then safeguarding access to healthcare and protection for the entire population who needs it badly. Thank you.
Thank you. Thank you, Dr. Zakaria. The next question will go to STAT, Helen Bransville. Helen, over to you, please.
Thank you very much for doing this, and thank you, Amna, for taking my question. I actually would like to squeeze in two, if I could. The first for the DG. Dr. Tedros, do you have thoughts about the U.S. plan to establish a quarantine and early treatment center in Kenya rather than allow Americans who may have had exposure to Ebola in the outbreak zone to return to the United States? And the second question would be for Dr. Murthy. Could you tell us a little bit, please, about the status of trials for the antivirals and other non-vaccine medical countermeasures? Thank you.
Thank you, Helen.
Thank you, Helen. We're working with the US. We collaborate at all levels, expert level and high level. We share information, and they're also investing, they're supporting financially, and I know they will increase their support. There is strong commitment at all levels, and I'm really glad to see that. So for the response, I think that's the most important part. With the rest of what they're doing, I think based on their risk assessment, they have, they can do whatever they think is right for them. But I really appreciate actually the strong commitment and support I see in responding to this Ebola outbreak, and I'm in touch, including my level, by the way. Thank you.
Thank you, DG. Dr. Vassi, for the question on the status of clinical trials, please.
Yes, thank you for the question, Helen. So I think that this is good news in a way, much better than we've been in outbreaks. And this is really the work, the preparedness work over the last several years that is bearing fruit. So is in advanced stages of preparation now, integrated into the scaling up of the case management, the patient referral pathways. So it's really central that trial is integrated into the broader treatment work. But we understand that the protocol has been approved by authorities in DRC and is going through that process in Uganda. The two agents there are MBP-134, a promising pan-Ebola monoclonal antibody, and remdesivir, which in the trial there are multiple arms, including a combination of those two. So that is most advanced because that protocol was written before this outbreak, and we were able, as a preparedness protocol. So the fact that we have these preparedness protocols approved before outbreaks is a development. Secondly, when we consider prevention of cases, we're certainly not waiting for the vaccines, in that we have another new development for an Ebola outbreak, and that is an oral antiviral. So obeldesivir, we haven't had this before in any previous outbreaks of viruses. We have an oral option for research. Here, I would like to point out the really close coordination between leadership from the national authorities in DRC and Uganda, Africa CDC, and ANRS, which is the lead filovirus cork that we have, collaborative open research consortium with the R&D blueprint, work works with to collaborate with scientists. All of these partners are coming together to write the protocol for a clinical trial looking at obeldesivir as a post-exposure prophylaxis. And again here, very close coordination with those working in the field for contact tracing will be very important. I think there is a possibility looking at this in a positive with the contact tracing. We will be able to offer potentially beneficial option to the contact list in this clinical trial. So the protocol and in fast development, it will still be at least 2 to 3 weeks before we can start that protocol. Thank you. I'll stop there.
Thank you, Dr. Vassi. The next question will go to Alice Park from Time magazine. Ask from our reporters, please keep your questions to one only in the interest of time, because we still have a couple of your colleagues waiting to ask their questions. Alice, the floor is yours.
Thank you. This is actually a follow-up to the previous questions about the state of trials. Dr. Tedros, I wonder if you can address to what extent there has been preparation since the previous Ebola outbreak in establishing R&D and having those protocols that Dr. Vassi just mentioned in place. And would this outbreak be the first time that we have something like that in place because of preparations before? And how much has that R&D and investment in that pre-work been impacted by recent cuts in your funding?
Thank you, Alice. We will go to Dr. Vassi again. Dr. Vassi. We don't have the connection.
Thank you.
Oh, yes, please go ahead.
I think this is an area that, sorry, I wouldn't put comes and goes here. I was saying that I wouldn't say it's the first time, but it is continuing to improve the preparedness work. So a previous outbreak in Uganda, again there was a very rapid initiation because of this preparedness work. But what we are looking to do with the corks is systematically.
Dr. Vassi, we can't hear you very well. Alice, can you please send a question to media@who.int?
Preparedness protocols and treatment.
Dr. Vassi, I'm sorry. Your sound is a bit choppy, so we can't get everything you're getting. We're asking Alice to contact us via email, and we will forward that email to you for the responses. The next question goes to Ashley from Bloomberg. Ashley, please unmute yourself and ask your question. Okay, some problems. The next one is Jen Rigby from Reuters. Jen?
Hello, thank you for taking my question. I just wanted to ask very quickly, is the WHO putting out situation reports? A couple of people have asked us about them, and we would also be interested to see them if they are. And then very quickly, about when the outbreak began, people have been saying to us on the ground that it's been discussed that it started in January or February, and I just wondered if you could comment on those dates, please. Thanks.
Yes, thank you, Jen. We will go to Dr. Abdi to start us off. Dr. Mahmoud.
Thanks. As I mentioned earlier, this is an ongoing investigation. The team are in the field trying to tell the story, what happened when the death started. Initially, we were aware about April, but as any other outbreak, it will take us time to go all the data. And once we have full picture, we are hearing from community, we are sitting down with them. So the anecdotal report of the team there is very important. So listening to the community, when did it start, how did it present, all that work is going on. And once it's finalized, through the INSP, we will share that. But right now, they are all dates around. I will request for us to wait for the full report on that. It will take time. So what we've been saying is this outbreak started earlier. How earlier? Time will tell, but weeks, months. But what we received from there was the initial, and maybe we will see it in our disease outbreak news, is that case that was confirmed. But before then, the investigation is going on as it's been finalized.
Thank you, Dr. Mahmoud. DG?
So I think I want to, of course, I agree with Abdi. There are many, what do you call it, scenarios. Of course, could be January, could be February, March, or April. I think proper investigation is needed, and we're doing that. But I think the focus now should be on the response. It's very important that we focus on the response, because as we said, the virus is ahead of us and we need to catch up. Of course, as I said earlier, there are things I observed in the field that gives me hope. So we need to move faster. Then the second part is, I think we have to understand that this outbreak is very complex. Number one, there is active armed conflict in that province. Many armed groups operate in that province. And the instability, the insecurity, I think impacts the detection and the response as well. And then, of course, there is displacement. Close to 1 million people already displaced, but the last few months alone, more than 100,000 new. And the mobility as well increased the complexity. And there is hunger in that area because of the chronic insecurity that prevents people from doing their daily work, and many dependent on food aid. And of course, the last is, which makes again this outbreak or epidemic complex, is the virus. This type of Ebola virus is rare, and since it was discovered, it's 19 years, and 2 outbreaks. The first one was in 2007, the first ever, and then the second was in 2012, and of course there was like 16 years with no cases, and the test kit was not optimized for this rare type of the virus. But at the same time, not enough cases, although we have candidate vaccines and treatments, but not approved vaccines and treatments. That adds to the complexity. And of course, the other part is the symptoms of other disease, which is very similar to this disease. Especially malaria is very, very prevalent in the area. And the health workers we have spoken to actually reported super infections. You know, you find someone positive for malaria and you treat for that, but in addition to malaria, that person has Ebola. So that also adds to the complexity of to the layer of complexity of the situation. But as I said in my speech, the other important element of the complexity is the mistrust from the community. When we spoke to communities, they told us that Ebola is not real. It doesn't exist. This is something that's being fabricated by foreign forces. That's what they said. And others believe other things may be related to poison or so, and the community mistrust is high. And even when it was circulating, coming forward to the health facilities is actually not that easy for many, but due to the other. complexities as well, which I said. So I think it's very important to understand this, and finding out how it started, when and why. All these questions will not be easy to answer. So that's why it takes time, because it's not easy to answer when it started, given the layers of complexities. And why also should be addressed. It's only when you know why it was delayed, then you can address those reasons, and then, of course, prevent the same thing from happening in the future. And the other important element is, of course, investing in surveillance, investing in health systems is important. But at the same time, as Ardi said, investing in prevention is important. Investing in addressing the root cause is important. And really trying to push, especially the One Health agenda, addressing the spillover issue, because we know that this happens normally with a spillover, and addressing the hygiene, safety part of, using bushmeat is very important to address it. And there are cultural issues with funerals and so on that should be addressed as well. And the government is really committed. During our discussions, they told us they're committed to address the root cause of this problem. Some of the community members we have spoken, they told us that we know this is related to Nyami Apori, in the local language for bushmeat. Of course, it's the safety and hygiene part which should be addressed. And this needs actually honest discussion with the communities, and communities taking responsibility and having a type of social movement to make changes in terms of having safety and hygienic practices. And of course, the other cultural issues also that can be addressed while observing and being sensitive from our side to the cultural practices of the communities. So talking to the communities, listening to the communities, understanding what the problems are, and asking them for solutions. They know, by the way, the problems better than anyone who would go from elsewhere. And they know the solutions. And listening to them and helping them with addressing the challenges with the solutions they say is important, of course, with the technical support that we can provide. But all this with the government's leadership. And that's why WHO is saying there should be one plan, one budget, one report. The government's leadership, strong community ownership, properly coordinated partner support, we can stop this epidemic as soon as possible. Thank you. Back to you, Amna.
Thank you, DG. Given the time, we will have time for one more question. Jonathan Lambert, NPR, please unmute yourself and ask your question.
Thank you. My question is related to an earlier one about vaccines. I wonder if WHO can comment on the announcement from CEPI earlier this week and talk about whether this infusion of cash might alter the timeline for how soon vaccines might be tested. And I also wonder how WHO is weighing the three candidates, given IAVI seems furthest along in terms of animal testing, but Oxford's and Moderna's may be quicker to manufacture. Thank you.
Thank you, Jonathan. Dr. Vassi had to leave, but we will go to Anaïs Legand, Technical Officer for High Threat Pathogens at the WHO Health Emergencies Program. Anaïs?
Yes, thanks a lot for your question. I will try to answer as Vassi would, but probably we can follow up in writing as needed. To your question, what WHO think of CEPI's announcement, we are very happy to see commitment to fast-track candidate vaccines, obviously. What is important to remember is while manufacturers are scaling up the investigational product to be produced, they will still need to undergo some testing to make sure that they are safe, they do not create harm to patients. And this will require some data because, again, whatever clinical trial is being done needs to comply with the highest ethical ground as covered by many conventions. And again, while these products are becoming available, our focus is to strengthen the known interventions that proven effective in the past to control outbreaks, but also to prepare for when this candidate product may be available. Thank you.
Thank you very much, Anais. We have come to the end of this press conference. Going to Dr. Chikwe Ihekweazu, just to check if you have any further comments, anything to add to discussion so far?
Yeah, thanks, Amna. Just to say that our DG has clearly outlined the complexities of the context. Having said all of that, just to report that back, that a response is growing. It's magic is happening, and if you see a treatment center being born out of really, a derelict site, colleagues working together, not only to provide treatment, but to provide water, hygiene, sometimes even food setup, bringing hope back to communities. I went around yesterday to meet all our partners, speaking to them. The energy is growing, the community is growing. We're cleaning out our line list. Like you see, yes, the numbers are changing, but in the next few days, we will have clean data to share with the world on what is happening every single day. So I just want to leave this press conference with a message of hope, of the growing collection of effort and energy in solidarity with the government and people of the Democratic Republic of Congo. And I am confident that with all of this together, we will get on top of this. So just to share with you the thoughts of the hundreds of us in Bunia right now supporting the response and the energy I feel in everyone in Bunia right now. Back to you, Amna.
Thank you very much, Dr. Chikwe. And thank you to all our other speakers, journalists online and in the room. Apologies to those of you whose questions we couldn't take due to the lack of time. You can always find us at media@who.int. Please write and we will try to assist with your requests. As always, we will be sending the recording of this press conference to our media list. And now turning to Dr. Tedros for any final words.
Yeah, thank you. Thank you to members of the press who joined us today in the room and also those online, and see you next time.